Hello there, my name's Dawn Skelton. I'm Professor of Ageing and Health at Glasgow Caledonian University, and I specialise in falls prevention research. Thank you for inviting me to speak to you at the Northeastern Yorkshire Virtual Falls Conference about falls in social care. I'm going to do a bit of an overview, and then you're going to get a series of more in-depth conversations from a number of other speakers after this. So first of all, I'm just going to talk to you overall about the problem of falls in social care, some of the ideas for action, and move through some of the content and detail regarding falls. So first of all, I just want to declare a conflict of interest because apart from working in research, I'm also Director of Later Life Training, a not-for-profit training organisation that trains health and exercise professionals in falls prevention. Anyway, what am I going to cover today? I'm going to cover a little bit about how big a problem falls are in social care, a bit about the risk factors and the need for a multifactorial assessment and intervention approach. I'm going to touch on the biggest problem, which is inactivity and sedentary behaviour in that setting, and then talk a little bit about barriers in terms of getting people engaged in falls prevention in social care. And last but not least, a few ideas for action, but I won't step on the toes of some of the other speakers who are going to go into a bit more depth. So first of all, why do we see falls in social care? Why do we see falls? I mean, essentially, falls are a symptom of frailty. Not all fallers are frail, and not all frailer older adults are fallers. But as we get older, time takes its toll on our muscles and our balance systems. Disease will add to that, and disuse or lack of movement. All of those three things contribute to human frailty. In terms of falls in care homes, we know that certainly compared to falls in community dwelling older adults, where around about a third of people will fall each year, in a care home setting, we're looking at least half to 3/4 of residents will fall each year. In fact, falls are about 3 times more common in a care home setting than they are in community dwelling older adults of the same age. Serious injuries are also greater in this population. So whereas in the community dwelling older adult population, serious injuries are around about 10%, in the people living in care home settings, we're looking at serious injuries accounting for nearly 1/4 of all falls. And 40% of admissions from hospital into care homes are due to falls. So it's a big issue, and it's something which I'm sure many of you have come across in your workplace. What about those receiving care at home? There's a lot less research actually into this area and this population of older adults, but one study has looked at the prevalence and has found that it's give or take about 70% of people who are receiving care at home will have had one fall in the last 6 months, and approaching 30% are multiple fallers, so they'll have multiple falls in that past 6-month period. In this setting, they're more likely to fallers are more likely to have visual impairment, be aged over 85, have significant environmental hazards in the home, may well have a neurological disorder which affects their balance perception or their movement patterns, and they have nearly always had previous trips or slips in their history. Approaching half have a fear of falling, and that will lead to a lack of activity, which increases their risk of falls over time. And in this setting, it's around about 80% of these falls lead to some kind of injury, and about half of those lead to some kind of hospitalization. So actually, this is a group where we really need to focus our falls prevention activity, and perhaps hasn't been, and certainly hasn't been in research, a focus of activity. So as I said before, falls are often a sign of frailty, and certain things can just tip someone over into being dependent or having issues. And for example, a minor illness such as urinary tract infection can literally turn somebody from being a perfectly reasonably capable person moving about independently in their own home to having a fall, or more likely the UTI caused the fall, and then they will avoid activity for a while post-fall, and it'll take a while to get them back into a level of function they're independent again. Interestingly, without that extra reserve, so without bringing their function back higher such that a minor illness tips them under, it means that we're just getting a revolving door. Essentially, we need to make sure that we have spent time bringing up their functional reserve such that these minor illnesses won't affect them quite so much. And we know that without that reserve strength and fitness, all sorts of things can affect the ability of somebody to stay upright. And I'll come back to that a little bit more later. So what are the risk factors for falls in community dwelling older people? Well, the biggest risk factor has always been history of falls. In almost every study you look at in any setting, if you've had previous falls, you're more likely to be a faller in the future. But otherwise, it's gait problems such as walking aid use, physical disability, disabilities in activities of daily living. You'll notice that in there are also neurological issues such as Parkinson's, use of anti-epileptic drugs, dizziness. But interestingly, I hope you also see fear of falling is an independent there. So actually, if somebody is concerned about falls, they change their movement patterns and often they reduce their physical activity considerably. And this puts them at higher risk in the future for another fall. Fear is a big issue. And this is just a quote from someone who's only 60, not far off my age. And she's had a couple of bad falls, and it's the fear that's restricting her. She doesn't want to go outside in case she falls. And of course, that will severely constrict a person's quality of life. What about in care home residents? Well, there's a huge overlap, as I'm sure you'd expect. So having had a fall in the last 6 months, being older, having dizziness, cognitive impairment, physical impairments, balance problems, gait problems, difficulties doing two things at once, dual tasking. There's a classic paper in the Lancet about stops walking when talking, and you may well see this in that setting. And that's basically because cognition is such that they haven't got the processing power to do more than two or three things at once with purpose. So they have to put all their cognitive processes into one thing. And the stops walking when talking is that in order to preserve their gait, they decide to stop walking while they answer your question. Wandering behaviour has also got a risk factor in that care home setting. Medications, essentially the same medications that you see in community dwelling older people. And we have a specific risk factor of wearing slippers in that care home setting. So footwear is also important. So what about interventions to keep people upright? Well, in terms of community dwelling older people, we have a large number of studies now, and the Cochrane collaboration have done a systematic review of all of those studies, and in particular looked at multifactorial assessment, looking at the multiple range of risk factors that might be important to an individual, and then multidisciplinary intervention based on that assessment. And those sorts of programs do reduce rate of fall. So if someone is having falls, then you will be able to reduce the number of falls that they have in time. But there doesn't appear to be a difference in the number of people who fall, hospital admissions or medical attention. There's a possible reduction in fall-related fractures, but this is small and low certainty evidence. In terms of the evidence for the multifactorial interventions, then home hazard assessment with a behavioural intervention, medication review and action, and exercise, particularly strength and balance exercise, are the most effective parts of those multifactorial interventions. But interestingly, exercise interventions alone were as effective as multifactorial interventions. Not that I think you should all rush off and just do exercise, because there are many other reasons for falls apart from poor gait and balance. But it is important, if you're doing a multifactorial intervention, not to forget the most important part of that, which is exercise. And in terms of exercise for preventing falls in community dwelling older adults, we see a similar reduction in rate, but we also see a reduction in the number of people who fall, and a reduction in possible fall-related fractures and in falls requiring medical attention. There are stars next to those because the evidence is not as robust. Some studies haven't shown a change and some have. But the important thing here is that not all exercise is the same. So there are key elements for that exercise to be effective. It has to properly challenge balance. The person has to feel wobbly. In other words, seated or standing up and holding on for dear life is not going to change your balance over time. You need progressive strength training in order to build the muscles, all the muscle groups involved in good posture, upright position, and movement. You need functional movements. So in other words, you want to ensure that your exercise is mimicking functional movement as well. And at the moment, we're looking at a dose of around 50 hours. That could be delivered about 3 times a week. Looking for about 2 hours of exercise over that week. And of course, we are therefore looking at about a 6-month program. So any programs which are shorter in duration or dose are unlikely to have a significant effect. What about in care homes? Well, the evidence of multifactorial interventions, sadly, is uncertain. So there are studies that show benefit and other studies which don't on both the rate and the number of falls. Even exercise doesn't have the same robust evidence base in a care home setting. And certainly medication review doesn't appear to make a difference either. What we do know is that vitamin D probably reduces the rate of falls, but only in residents who are vitamin D deficient. So again, it's not a blanket formula to give everybody vitamin D. Just to come into a little bit more depth, and the reason I have may here is because, as I said, some studies have shown a reduction and some haven't. And I think part of this is to do with the intensity of the intervention and the number of people that engage in it. But essentially, it may reduce the number of fallers and recurrent falls, and may reduce the number of hip fractures. But again, very small number of studies on this. Certainly, this doesn't seem to be an awful big change in the rate of falls or other injuries due to falls. In terms of exercise, it will reduce the rate potentially, but the studies, including the frailest, actually can see an increased risk of falls. So reminder that in the frailest older adults, you need to really be considering how you give that exercise program, who gives it, and when it's given and for how long. Tai Chi didn't show any effect on falls in this setting, but did reduce fear of falls. In terms of medication review, we know that there's no change in the rate or the number of fallers, but it is a significant component of the multifactorial interventions that did reduce risk. Staff education is an interesting one, and you'll hear more about that in a specific talk in this session, but we do know that if you just do a bit of passive education with staff, i.e. give them some leaflets and something to read, it doesn't seem to make a difference. But if you do more intensive education on reducing falls, so things such as group education programs where you do peer discussion, information, audits and feedback, so it's a continual process, then there is a reduction in the rate of falls. We have one study showing that if you engage your residents and family members in an understanding of falls prevention, then you can see a reduction in the rate of falls and the fear of falling. And in terms of hip protectors, we see no change in the actual number of falls, but there is a reduction in hip fractures as a result of falls. So an important point to remember in that setting, as we do see so many hip fractures in that setting. What about falls prevention in those receiving care at home? Again, very few studies on this, unfortunately. It's an emerging topic. But what we do know is that it's intensive, again, this intensity of the involvement that makes a difference. So this particular randomized controlled study was looking at people receiving care at home. Half of them got a normal care and half got a specific set of home visits from a multifactorial team, which include included the manager of the care services program, a nurse, occupational therapy, and physiotherapist. There was also input from geriatrician and dietitian if needed. They had a case conference monthly on each individual within the program, and they also looked at educating the clients about that as well. And over that period, the intervention group had on average about approaching 20 home visits over a 6-month period, and those all lasted round about an hour. And the input differed depending on the profession, but mostly it was nurse, physio, and OT visits. Less so was it the case managers or geriatricians or dietitians. What we do know is there was a reduction in reported slips and trips and an improvement in quality of life. But overall, there was no reduction in falls. There was only a reduction in one subgroup of that study, and that was in men in the younger age group, because they were only recruiting over 75s. So the 75 to 84 age range, there was a reduction in rate of falls, but no in the older or those with a higher risk. So the suggestions from this group were that essentially we should be intervening before people get too frail or too old. Otherwise, it's much harder to make a difference to falls. Another piece of work looking at falls prevention, this time in sheltered housing residents. And this was another randomized controlled trial with 18 assisted living facilities, mean age of 78. And it was a 12-week program where they took part in exergames. These were games which mimicked the exercises out of proven exercise programs, such as Otago and FAME, Falls Management Exercise. And it was supervised by a physiotherapist that went in 3 times a week on a one-to-one basis to allow the residents to try exergames safely and be progressed over that 12-week period. There was a very large improvement in balance. There was a big reduction in fear of falls and in pain, and there was a significant reduction in falls. It was cost effective, even with the one-to-one supervision. So an interesting approach, and the exergames, although they mimicked the exercises, could be considered much more engaging because they were all attempting to win prizes and beat their previous scores. So they quite often did more repetitions than they might have done with a normal exercise program. So just want to run through a few guidelines which are available, but just a heads up that on the 30th of September this year, we will see the launch of the World Falls Guidelines, and they go into quite a lot of depth about reducing falls in people in care settings and in community dwelling older adults. But this, at the moment, I'm basing my next few slides on the clinical practice guideline, which was published also in this year by Daniela Schroberer and her group. So first of all, this clinical falls assessment guideline recommended that every older patient should be systematically assessed for falls risk when admitted to hospital or nursing home. But I would also posit that's important when they are first brought into a home care service. The assessment should be based on observation and questioning for falls risk factors, but not use a tool. And that's quite important because no tools have been found to be particularly accurate or predictive with frailer older adults. By collecting frequent causes of falls in that particular setting, specific risk factors can be identified. They might be environmental, in other words, multiple people fall in the same area, or it might be some other reasoning. But essentially, it's always important to look at the causes of falls post-fall with each individual to see whether there's a pattern happening that can be addressed. I'll come back to the guidelines throughout the rest of my presentation, but I just want to address, first of all, some misunderstandings about physical activity and exercise. So as I mentioned earlier, we need challenging balance exercise with functional strength work. We need a dose of about 50 hours, and we need it to be on a frequent basis throughout the week. So at least 3 times a week for about 2 hours. So what we do know is chair-based exercise does not reduce falls. So in the care setting, it's no wonder that exercise alone rarely works because most often the residents are sat doing the exercises. Falls mostly occur when people are moving, and therefore you need to mimic those activities in your exercise program if you want to reduce falls. So any activity program which is predominantly chair-based will not reduce falls. Improving strength and balance does not necessarily mean you'll reduce falls. So you can improve strength in a seated activity program, and actually you can make some gains on balance also in seated, although you make much more in standing. But there are many studies, in fact, almost half of the Cochrane Review studies have not shown a reduction in falls, a significant reduction in falls, and they've all been based on strength and balance. So it's more than just doing a bit of strength and balance. We've got to think wider than that, and we've got to be thinking functionally. Doing a couple of exercises that appear in any proven program won't necessarily reduce falls. You have to do the program as it was originally done in the research, to the same intensity, delivered by the same people. Otherwise, you won't see you won't see a reduction. And we've seen a number of studies which have not been kept fidelity to the original research programs and haven't seen a reduction in falls with that known program. Gentle exercise will not challenge someone's nervous and muscular system enough to lead to a change that means you're going to have a reduction in falls. And this is why getting volunteers and staff members in those settings to try and get people to do exercise doesn't necessarily work, because often they're not pushed hard enough or challenged hard enough for physiological change to happen. And that's why the importance of trained instructors and therapists in those settings with these people. And you know what? There's a lot of dropout, yes, but older adults will engage if they know why and what it should feel like. Nobody particularly likes intensive exercise, and therefore the ability for them to understand and have the physical literacy to understand is really important. And particularly to understand that if they engage in an exercise program to reduce falls, they shouldn't sit the rest of the time, because in the long run, that's not going to help either. And from that, I move into my last few points that I want to make in this session, is that it is not safer to just sit. In fact, yes, of course, if you tied someone to a chair, they won't fall over. But essentially, if they don't move from a chair for long enough, their muscle will decline, their muscle strength and mass, their balance, coordination will decline, their flexibility will decline, and all of these things will increase the risk of falls. And we know that if someone's fearful, they reduce activity, they fall more, and they become frailer quicker. So falling is a big issue in this setting, and with frailer older adults and in people receiving care at home. And we do need to try and address this, or it affects all aspects of their lives. So how much do people sit in these settings? Well, if you put objective monitors on people to measure position, we can see that residents in care home settings spend nearly 80% of their day sitting. 14% in very low activity, so generally walking very slowly to the toilet or to a different room, and less than 1% in moderate to vigorous physical activity, which we know makes a difference to health. So on the whole, care home residents are extremely sedentary. This sitting is an interesting thing. First of all, we know that even short-term effects of sitting in extremes of temperature make a difference, and many care homes are very warm. So if, for example, you look at this particular study on the left, where older adults were asked to sit in a warm room, 30 degrees, for only 45 minutes, and basically things were measured before and after their sitting in that period in that temperature. And you can see in just 45 minutes of sitting in a very warm room, so think back to the heat wave earlier in the year, they'll have higher blood pressure, increased postural hypertension, so they're more likely to get dizzy on standing, and they have a shorter distance walked in 6 minutes. Their stamina is reduced just from 45 minutes of sitting in a warm room. And if you go into a cold room, and again, we could worry about the heating effect, heating costs nowadays, and whether people will heat their homes if they're receiving care at home, then we know that a cold room, only at 15 degrees, for 45 minutes will lead to a lower muscle power, lower sit to stand velocity, and slower walking speed. And all of these are risk factors for falls. So what does happen when people sit all day? lots. And we all know this. If you sit for very long periods of time, you'll get stiff. You will find that everything's a bit achy. You'll find perhaps you've got a bit of pain appearing. You'll find perhaps you're dizzy on standing. All of these things lead to problems with the body. We know inherently that sitting does this to us for long periods, but it also affects our psychosocial and psychological health as well, remember. And we know from many research studies, people meet physical activity guidelines in a week, so they do 150 minutes of moderate to vigorous physical activity. If they are very sedentary the rest of the time, compared to people who are not very sedentary, they will have more chance of having high cholesterol, high plasma glucose, therefore more likely to have type 2 diabetes, more likely to have a high BMI and waist-hip ratio, so more likely to have strokes, more likely to have reduced muscle strength, bone density, and frailty, and more likely to fall. So prolonged sitting is not good, and we do need to try and break up that period. We also know that people who are less active become frailer quicker than those who are a bit more active. There's a unidirectional relationship between frailty and activity. And those people who sit for more than 8 hours of their day, that's self-report, so we're probably looking at more like 12 to 14 hours sitting if you actually objectively measured them, then they're 3 times more likely to be diagnosed with frailty than those who sit for less than 4 hours a day on self-report. We know that sedentary behaviour and sarcopenia, which is a syndrome characterised by progressive and generalised loss of muscle strength and mass, that people who sit for longer are more likely to have sarcopenia. And for each extra hour of sitting, they are increasing their risk of sarcopenia by 1/3. So breaking up prolonged sitting is a really key part of falls prevention in these settings and with frailer older people. And back again, we know that people who sit most in a day have a very much higher risk of falling. And just to give you an idea, they also are more likely to be fearful of falls. And there's actually a cutoff point for sedentary behaviour to discriminate fear of falling. So if people sit for more than 4 hours, they're far more likely to be fearful. And fallers, we know, spend more time in sedentary behaviour than non-fallers. So these things really, what we want to try and do is promote breaking up long periods of sitting to make a difference. And of course, if these people go into hospital, they often come out even less active and more fearful. So we've got a fair amount of research going on now about the harm of not being mobilised in hospital or not mobilising in hospital. And here's an example where we happen to have a monitor on a sheltered housing resident before she broke her arm, and during the period she was in hospital, from that break and the period home. And pre her accident, she was spending around about 70% of her day seated. And in hospital, she broke her arm, remember, she was spending about 90% of her time seated. And then even 4 weeks post-discharge, she was still more sedentary than she had been prior to the break. So this big problem about what happens when people are in hospital and the effect it will have on physical function when they're home. There are many reasons why there might be some activity restriction, not just from the individual, actually, because they're fearful, but also potentially the staff and people that work with that individual. And the frailer they are, the more likely they're going to be encouraged to sit while something is done for them or to them rather than with them. So a lack of time, lack of staff, mobility plans, there's all sorts of reasons why people are not encouraged to move, but we do need to break through these barriers and make a difference to people. There's a real risk of us actually doing nothing. So this is just a randomized controlled trial where they spent time looking at the control group, not just the intervention group. This was in a care home, and they received 3 months of an individually tailored exercise program delivered by trained therapists or trained exercise instructors. And the intervention group got significant improvements in balance. They improved their general physical activity, their transfers, and so generally good outcome in that 3-month period. In the control group, there was a significant deterioration in activities of daily living, balance, and transfers. So actually, we're perhaps doing harm by not engaging them in regular exercise to make a difference to the trajectory of their aging. There are many lovely examples of how we might think more about how we work with our residents or people receiving care at home. And here's just an example of a care plan used in Lanarkshire. Leanne McAnally's email is on there. You can get hold of this, but there's plenty of them around now, just to give an idea for all staff that come across to know what the mobility plans and suggestions might be for that person, but also for that person to have a record and a reminder to move more as well. And in the care home setting, we've had some really lovely improvement bits of work. This is some work from the CAPA, Care About Physical Activity programme, an improvement programme by the Care Inspectorate in Scotland. And there's a lovely resource, and that web page has got some fabulous things to download and have a look at. But essentially, it was training for all staff involved in the care of residents in care homes. And there was a pack. They spent a lot of time talking and engaging staff in how to do the motivational behaviour change that might be needed to help residents move more. And an evaluation of that showed a reduction in sedentary time, a reduction in the number of people that needed help to get out of their chair to move, and essentially 80 minutes a day more movement of each resident at 20 weeks, which was fabulous. But more importantly, a decrease in falls risk and the number of people falling. So increasing physical activity in a setting did not increase falls. It actually reduced them. There was also a decrease in contact with medical services, mobility, happiness, and all sorts. So really, we need to be considering more movement more often with older adults. And we don't necessarily have to go straight into a 12-week intensive exercise program, which many times they won't want to engage with. This is an example of a study in sheltered housing where they were encouraged to stand up once an hour of their waking day just for 30 seconds, didn't have to walk anywhere, they just had to stand up and sit down again. And over a 12-week period, there was a significant improvement in their ability to do timed up and go and the amount of rises they could do in 30 seconds, both of which are risk factors for falls. And they reported more energy to do more. So frailer older adults are more likely to break up sitting time than they are to engage in an exercise group. So perhaps think about sitting and breaking up sitting. It's really never too late. No matter what the age of the person, it is possible to regain lost strength and improve balance. And for example, there was a nice randomized control trial in those receiving care at home in Norway, where the physiotherapist went in and encouraged people to do home exercise, the Otago home exercise program. They did 5 home visits over those 12 weeks to encourage the progression of those exercises that they were doing on their own. And essentially, there were good improvements in quality of life and in balance. So a reminder that we can regain lost ability to do tasks. I'd also direct you to a fabulous resource online called React to Falls, which has got a lot of very useful information on staff education, and in a large randomized controlled trial showed a reduction in falls rate, and it was cost effective. There are both web pages and apps to support that, and you'll hear more about that from Pip Logan in another talk. So just finishing up, it's really important that we help people be more resilient in these settings. We need to train all staff in falls prevention. That's everyone from catering staff, people visiting, care staff, friends and relatives as well, actually. We need to encourage more standing and walking movement in residents and in those receiving care, because that might make a difference to the future trajectory of frailty. We need to engage residents in seated strength and stamina exercise, even if they won't be involved in other things. And certainly those can be done by staff members and by anyone that comes in, even volunteers. But if you want to deliver specific falls prevention exercise, the evidence is clear. You need someone who's trained to do that and to feel confident to progress somebody, irrespective of their medical conditions, into challenging strength and balance work. And in an ideal world, refer older adults who fall to rehabilitation services, to the local falls services, because they may well be able to find other risk factors that they can intervene on to make a difference. So I'll just finish up reminding you that our world guidelines on falls are being published on the 30th of September in Age and Aging, and encourage you to all work, everyone you work with, to sit less and move more for falls prevention. Thank you.